Visual cortex. Okay, so again, when we make a fist, the occipital cortex is going to be where your arm is connecting into your wrist on the very back end here. And on the medial surface, we're going to have this calcarine sulcus, or it's a hook-like sulcus, separating the superior and inferior lobe. We have the cuneus, the cuneate lobe, and the lingual gyrus, this more inferior aspect. And in this image, we can again inflate and expand. So visual cortex is going to be located here. We have in color various retinotopically mapped areas of the brain on average from about 20 or 30 subjects. And as we inflate and unfold that, we can see the occipital lobe, multiple distinct visual areas. Each one of these colored areas of cortex has a visual topic map from central out to periphery map of the visual field, of one hemivisual field, as we'll see in a moment. But point to mark here is there's our calcarine sulcus, primary visual cortex in the purple here is where this is located. We've got areas for motion processing and a multitude of other areas. That's 2 more lectures of material on that one. But there's our visual cortex. One last piece I'll put onto there is, as a review, you have to remember after the optic chiasm, we had our optic nerves come to the optic chiasm. About half the retinal ganglion fibers cross, so that we have going into this lateral geniculate nucleus, you've got all the input from the left nasal retina side is going to be looking at your left visual space, goes to the right side of your brain. And in your right eye, that temporal retina, which is also conveying the left visual field, is going to the right side. So everything in the right side of your vision, of where you're, if you're looking straight ahead, and if I put up my fingers here, how many fingers do you see? That is in your, I'm assuming your right visual field, that is going to your left occipital cortex for conscious level perception of what you are seeing there. And so that is occurring at the cross, the optic chiasm. So once we get behind the optic chiasm here in the optic tract, you have a hemifield representation. The contralateral hemifield is represented here, going to the LGN, lateral geniculate nucleus. And to memorize LGN from MGN, L is for light, light LGN. M is for music or sound. Sound processing is more your medial geniculate nucleus. LGN is light, lateral geniculate nucleus. Okay. And then we have our optic radiations that would be coming back here to the calcarine sulcus and these other visual areas. And these inputs are all retinotopically organized or visuotopically organized. So you can have lesions back in here, taking out Meyer's loop or optic radiations, and you can tell or predict what kind of visual field deficits the patient's going to have. Won't go into those details, just to remind you that those are kind of high yield concepts that come up on STEP exams. Bigger picture level, what's going in the visual cortex, then we start thinking about streams and major pathways. So as you go dorsally directed from, say, these magnocellular layers in the LGN to various areas of cortex to more parietal superior regions are going to be involved with your perception of motion and location. Where are things in space? So if you have to reach out and grab your beverage, where is it in space? Then you have information flowing along the inferotemporal cortices, and these are going to be more about, well, what is that? Is it, what color is that cup? Is it blue? Is it red? What is the shape, if you had to state what its shape is? And so the information of form, or what is it, is going to be going down toward vision for perception, towards these inferotemporal regions of the brain. So the gross level object for action going dorsal, and the object for what is it for perception going more ventrally. Then interestingly, with carbon monoxide poisoning, it's not terribly uncommon to have what's called a condition called blind sight. For whatever reasons, this region's cortex is more sensitive to carbon monoxide poisoning. And if you take out both the left and right occipital cortices along the calcarine sulci, for instance, you lose your perception of what you are seeing. However, conscious level perception. However, you can still, quote unquote, see and have more reflexive level of vision. So for instance, here's a patient with blind sight who's and the doctor's here, okay, what is the orientation of this bar on the TV screen? And they're like, well, consciously, I can't see anything. Well, just make a guess. All right, horizontal. Like what? So that information is getting through to the brain in other areas, but not at a conscious level of perception. And so this and other lesions like that give us some more clues to understanding how vision works in the human brain. Still don't fully understand it, obviously, but there's some fascinating knowledge about different pathways and routes of information flow. And there are numerous other type of visual lesions, prosopagnosia, achromatopsias, and so forth, which again is topic of another lecture.
Dr. Lewis, is that
Yeah.
a permanent change that happens with the blind side, or does that heal over time?
My understanding is that's permanent. If it's yeah, my guess is permanent, but I don't see patients and I don't have a full answer for that. I would imagine you can have a condition where it could be transient, but with the carbon monoxide poisoning, once your neurons die, that's it. The central nervous system, they're not coming back. You're not going to be getting that conscious perception coming back.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.